Oh, hey, Chris.
Hey Chuck, how are you?
I'm fantastic. How are you?
I'm great. It's a Sunday morning. It's been very relaxing thus far. It's been really nice.
I'm guessing your day is not going to stay relaxing the whole day.
It's not. Lots of youth activities, including a hockey tournament this weekend and play dates and the whole nine. But we're doing a new thing for our episode today. I'm going to allow you to introduce it, but it required me to do more prep than I've probably done for our podcast in quite some time. So I was reading 6 articles this morning, and I decided to just, have the do it while on the Peloton bike and just kind of have my legs moving as I was reading. And it actually made me realize how long it takes for me to read an article because every time I would finish an article, I would look up and say, "Oh, it's like 12 minutes, man." Like it takes a
Uh,
while sometimes.
yeah, I would be about 2 articles into the bike ride and be done with the bike ride. But you bike longer and harder than I do, no doubt about that.
That's okay. I eat a lot, so I have to make up for it somehow. But yeah, no, so I did that, got the rest of my workout done, and then starting to prepare for having people over later. Gonna do a Puerto Rican themed menu, obviously inspired by Benito last weekend.
Oh, I love that. That's great. I have a lot of different ways I want to go with this. So first of all, in the interest of just introducing the episode, we do have a new effort. Greg Merrill is the new Journal of Hand Surgery editor, and he's working and he's empowered a lot of associate editors with specific focus areas. But one of the things he asked is if we would partner with the Journal of Hand Surgery to highlight some key articles, and of course, we're happy to do that and Nash and Macerena reached out with a list of 6 articles that we are going to profile, talking about the article itself, but also how it applies to our lives and how we think about hand surgery and the bigger discipline of kind of the world of hand surgery. And so I'm excited. What we're going to do today is we're going to pick 3 of the articles, and then our next episode will hit the other 3, but we're going to mix in lots of other things, including just a chance to catch up on a couple of things between me and you.
Yeah, absolutely. And I think this will be fun. It'll kind of be like the journal club we do for our fellowship in terms of, I think that yes, it's important to understand methodologic considerations, limitations, et cetera. So we'll talk a little bit about that, but obviously the point is to contextualize it and see how it relates to our, kind of regular practice. So I think we'll have some fun doing that. And those of you that are, looking at fellowships, it's actually a nice way for you to see how we would, break down an article in our journal club. So before we get into that, you did mention you've had an interesting trip with regards to looking at different practice settings.
I have, and some of the listeners may be familiar with this, and some definitely will not be. So, efficiency in the world of hand surgery is wonderful, and I think most or many hand surgeons, maybe most hand surgeons, are, focused a little anal retentive, perhaps, and focused on efficiency and case throughput. Um, I think there are joint surgery partners, that is, those who do total hips and total knees, are equal in that area of seeking efficiency. And yet it's even more vital for them because they don't do a large variety of procedures. And so standardization, which probably the concept appeals to me, I'm sure it appeals to you and all hand surgeons. So it's really interesting. And so we did a site visit to practice down in Atlanta, and a joint surgeon named Charlie DeCook, who many years ago started popularizing the concept of what he called 12 by 12. That is 12 total joints done by noon, which in and of itself sounds impressive,
Insane. Absolutely insane. But
absolutely insane.
impressive too. But yeah.
And I would say this. It was more impressive than that. And really, we met with Charlie the night before, had a nice dinner. And this was a group from our practice and also from the hospital system. He did 20 total joints done before 2 o'clock. And he did them well, most importantly. And they weren't cherry picked cases. They were thin patients and large patients. And some of it's very bread and butter. Hips are in one room, knees are in the other, right sides and left side. That's like the obvious stuff. But and we could spend hours talking about this and we won't. But I would say this, there is so much room for increased efficiency in our worlds. Hand surgeons have a little harder because of the diversity of cases. But we talked about room turnaround time, which is a metric you and I and our current system we talk about all the time, it's not what he focuses on. Now he doesn't focus on it because it's 5 minutes. But what they focus on is in the room to cut time and close to out of the room time. And those numbers are insanely quick as well. And they sort of live by this radical time transparency where every step of a case is clocked and shared, and patients wear a bracelet so they know exactly how long they spend in the waiting room, in the pre-op area, in the OR. It's awesome. And this has now been a couple weeks, and I would say I'm thinking about it even more today than when I left, and it's more impressive to me than when I was there. It's stunning.
Now, was there maybe one or two things that you think that you took home that could actually be operationalized in a setting like ours, big clunky academic center?
I think there are things that can be operationalized everywhere. The first concept and the most important is that your bottleneck, from those who like business school principles, or your constraint, is the surgeon. And it's the surgeon who determines your throughput. And so everything should be about making the surgeon more efficient. So that's like the principle that has to guide everything. And understanding times is really important. But I would say the second takeaway is you have to put resources at this to see what you can do. And what I mean by that is, uh, well, I'll say two things. One, it's like a pit crew when it comes to getting the patient in the room, opening packs, and then cleaning up after. All that people come in the room, 6, 7 people to get it done quickly. And that is like poetry in motion. It's everyone has a job, everyone knows their job, and they do it really, really well. And the final thing I'll say is everything is done in parallel, or almost everything, not in series. And I was at our big hospital. I was on call. I am on call this weekend, and just watching everything go very slowly. Step one, step two, step 733. It's crazy because all of these things could have been done simultaneously. So many lessons, so inspiring and so motivating.
Now you mentioned that hospital leadership came with you. I've actually heard about this trip from Dr. Nunley in a more casual setting. Uh, do you feel like the message was delivered?
The message was delivered. The hospital leadership, uh, of course, didn't believe in every single thing that was being done. It's a different environment, right? It's a private ASC, and it's just a different environment. But I think they realized there's a lot we could take away and apply today if they're willing to apply some resources. But this seems like a no-brainer. Apply a few resources, and if Dr. Nunley, our most efficient surgeon, who does 10 to 12 cases in a full day, and that's a full day, can do two more cases. He could definitely do at least two, four, six more cases in that full day. If he can do two more cases, it's a huge win for everyone.
You would think. I think that at least my skepticism is sometimes that perhaps incentives aren't or goals aren't always aligned between a hospital system and a surgeon. I'm going to leave it at that. But I think there's a lot to learn. Just talking to one of our hand surgery colleagues at a major privatedemic center in the southeast, he was talking about doing 20 carpal tunnels by noon, and honestly, I don't really want to personally do 20 carpal tunnels.
No.
But you could see that, with again resources dedicated to improving throughput and getting things happening parallel, not series, it can be done. And I guess we're just put it out there, we're getting left behind.
We are getting left behind. And it is not only, all parties have to be engaged: anesthesia, the surgeon, the staff. It's a process, it's a culture, and it would take some work, but it becomes a win for everyone if it can be done. So I've created a nice document summarizing things, and I'm setting up some follow-up meetings so we don't let this get lost.
So one more question I want to ask you before we move to our journal articles is how do you want to, obviously you do the same thing. You're, but you're running two rooms at an ASC or a hospital outpatient department. You're going to pre-op, you're marking patients, they're seeing you kind of flying around. What do you do when they say, "Hey, pretty busy today"? They got you moving. Or they say, "So how many surgeries do you do in a day?" You can only imagine. It's kind of a weird thing to discuss, but then if you're doing 20 carpal tunnels in the morning, you have to talk about that too.
You mean they being the patient when the patient
Yeah.
inquires about that? Yeah, I think it's good. I don't think our numbers when I talk about with patients, I never answer it directly. And I don't I feel like I'm always present. I think it's 100% safe, not cutting corners. If that number increases, I think the patients understand. They are explained everything. There's so much work done on the front end, on the office side of things, that when the patient in Atlanta gets to the surgery center, they sort of have an idea of what to expect. And it's to their benefit. A shorter case means lower infection time. A specialized team means everyone knows their job and is going to do it as efficiently as possible. And the list goes on. And so I do think communication on the front end, not day of surgery, is critical.
Well, and then also, I mean, also access, right? So, I mean, it's getting to your surgery sooner. I know that it's a 9-month wait list just to get in to see Dr. Nunley in the clinic unless somebody greases the wheel for you. So, access, but making people more efficient will get people the care that they want, especially as you get towards like the end of the year, that kind of thing. So,
That's exactly right.
why don't we acknowledge our first sponsor over at Practice Link?
Yeah, the upper hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/the upper hand.
I love it. All right. Should we jump in?
Yeah, so Nash and Macarena from JHS asked us to look at some of these articles. I think there are three that kind of come together pretty nicely in terms of general hand surgery practice. So the first article, let me just go ahead and pull up the front of it, that I want to talk about is about using telemedicine in terms of follow-up. And this was a study that was done out of the Harvard group. So this was done at Brigham, and it's the use of telemedicine postoperative visits between carpal tunnel or following carpal tunnel and trigger digit releases, a randomized clinical trial. The authors are Brandon Earp, Dafang Zhang, Kyra Benavent, Peter Ostergaard, and senior author is Phil Blazar. So I thought this was interesting. Before we jump into the actual article, do you use telemedicine at all for your post-op visits?
I don't currently. Well, I should say I don't unless patients specifically request it. It is interesting that increasingly I feel like my patients are coming from further and further away. And so I don't bat an eye if someone's from 3, 4, 5 hours away, much less if they fly in. But it creates logistical challenges. And so this concept is important. I generally, and this is not, my practice is not doing carpal tunnels and triggers where it would be easier to do a telehealth follow up. But I generally insist on seeing me for the first visit and then I negotiate after that, depending on the surgery. How do you handle it for your practice?
So I think people have heard me kind of evolve in the last couple of years towards dissolvable sutures and skin glue for carpals and triggers. So as I've gone into that, I now schedule patients with a post-op visit in person. But as I'm doing their wide awake surgery, I tell them, hey, these are dissolvable sutures. I expect your wounds to do well. We can always switch your follow-up to a telemedicine or a MyChart conversation or a phone call if you would like. It'll save you a trip in, but you're already set to see me in person just in case there are any issues. And I'd say probably the conversion rate on that's probably about 20%, which is nice because it saves them a trip in. It frees me up to kind of see less of the routine stuff in the office if they're doing well. So it's been nice for me.
Yeah, makes a lot of sense. So this study had 60 randomized patients to either an in-person or telehealth follow-up. All of them, as we said, were carpal tunnel releases or trigger digits. And patients didn't have a choice, which I think comes back to the take-home message. And they were assessed essentially with the Press Ganey outpatient medical practice survey tool at 2 weeks, with secondary outcomes being the same at 3 months, as well as a quick dash. So simplistic study design, I would say well executed with an important message.
Yeah, so I would say simple. I'd say straightforward. And RCT is always challenging. Like even if it's an RCT, and this is still a lot of people. I mean, even if it's a smaller RCT, it's hard logistically to do any sort of prospective research, and especially if you're trying to, when you're recruiting patients, telling them they're going to be randomized. So that their conversion rates, in terms of crossover, I don't really think they had much. They did have to pull some people out of the study. because sometimes it was like wound issues or something like that. I think these were all patients who were included only if they were going anticipated to have dissolvable sutures for their closure. So I mean, I think this is the right study design for it. I think they did a really nice job executing it. My only beef with it was probably the outcome measure that they chose. Perhaps, I think the Press Ganey Outpatient Medical Practice Survey, I was unfamiliar with. Obviously, Press Ganey is a really big company and a very important metric. But actually, so because I was unfamiliar with it, I pulled up some of the questions, and many of them are not related directly to care by the by that treating provider. And this was a PA that was seeing their patients, which I think is their routine practice. But the questions were very different, and there are a lot of them. So I think that perhaps if we were to try to fine tune this, you would find some kind of measure that would be a little more specific to the patient experience for carpal tunnel or trigger finger release and not so much about the overall healthcare experience.
Yeah, well said. And I too was unfamiliar with this particular press gating. I'm overly and overwhelmingly familiar with press gating as it affects us with our outpatient clinic visit satisfaction. But yeah, I think well said. And I think you're right. Um, Straightforward is a better descriptor than simple. There are no simple prospective randomized trials, even though this is probably one of the most straightforward ways to think about it. And I think it was executed well. This is interesting. It gets to the point that patients want to be involved in their decision making or decision making that affects their care. And so the obvious question is those patients who were assigned to a telehealth follow up who had lower satisfaction, had they been a part of the decision making to choose telehealth, would they still have been less satisfied?
Yeah, and I think there's just certain, I mean, obviously there's generational differences and there's just kind of patient preferences, You see it when you try to incorporate shared decision making in practice. Like some people just like, "Hey, doc, just tell me what you want to do. Like you're the expert here." Or it's like, why am you not including me in this decision? And you see it both ways. I mean, I read my online reviews. I got totally burned for incorporating shared decision making into fracture management. Nasty review online. So I think it's very different, and you have to individualize it, and you kind of have to, I like giving them the option. I, as a surgeon, like to see my patients post-op, make sure they're doing okay. I think that maybe that's a product of the fact that we don't have PAs and APPs in our system. So physician assistants or advanced practice providers. So I'm used to that, and I'm definitely not the most efficient because I do that. But I think that it's just how I was trained, and what I'm used to.
Yeah, I mean, as surgical practices look to become more efficient, having the surgeon become more of a technician is there is no doubt it is increasing, and we're probably going to continue to see those pressures. I'll say when I have clinics that really don't have post ops for whatever reason, I've been out of town or there's just no post ops, it's a very different clinic experience because those are the patients that A are typically happy, B, they're typically happy because the next step of their evolution post surgical is about to happen. And therefore, I'm happy. And, sure, lots of patients can be happy, but taking those out of my clinic would be tough, but it may be the reality that we face in the future. And many of our colleagues are without post ops today.
Yeah, absolutely. So I mean, I think that's you're right on all accounts. Those are the patients that give you an exhale, they revitalize you, and then on to the next new patient encounter in which you are going in cold and you got to be on the entire time. Not that you're not on for when you see your post-op, but it's definitely a different feeling.
Yeah, the last thing I'll say about this paper, again, I liked it, but the last thing I'll say is there are probably colleagues that are in the United States on the East Coast and West Coast that would love to have our patient population say, "Hey, doc, you just tell me what to do. I trust your judgment. This is your job. You know best." I don't think that happens all over the country or all over the world.
Yeah, no, I think that practicing in the Midwest is very different for sure. I think that there are a lot of patients who just come in because they want to be told what to do. And I remember residency treating patients in Manhattan, at least the ER part of it, but then also being in the clinic with the faculty. It's different. They're coming in with very different expectations. It's kind of like like I'm starting to have more people come in from out of town, like you've been doing for years, and that is a different visit because you have to make them feel like that however much amount of time was worth their trip in.
Yeah, that's a whole nother conversation, but very, very true. Should we, as we pivot, should we thank our other sponsor?
We should. So, tendon transfer success depends on proper tension, but that's not always easy to achieve. Checkpoint Guardian allows surgeons to use direct muscle stimulation for proportional control of contraction, helping assess excursion, tension, and repair strength intraoperatively.
Learn how surgeons are utilizing Guardian and tendon transfer procedures by exploring the technique guide at checkpointsurgical.com or contact your local Checkpoint Surgical representative to try it yourself. Have you done this?
So first, I've tried it. So it's the blue one for those of you that are simple. So the Guardian is the unipolar one, and that's the blue one. The Gemini is the purple one, and that's the bipolar. I've done it in some select cases, and I think maybe we could unpack that in a different episode. But it's exciting because it's nice to be able to have, it's kind of like when you have somebody awake, right? Being able to have them fire the transfer and check your tensioning, it's so useful. But obviously, many of our tendon transfer patients aren't awake.
Yeah. All right. What's next on the hit list for article review?
All right, so these GLP-1 agonists are everywhere, and I think it's important to understand how that may or may not relate to the practice of hand surgery. And this is actually an article we reviewed in our service journal club a couple of months ago. So this is GLP-1 agonists and common hand procedures, perioperative and postoperative risks and complications. First author is Troy Amen. Senior author is Steve Lee. This is from a hospital for special surgeries hand service.
Yes, and they list a couple other sites, Yale and Rush. I don't know if it's all emanating from HSS and those folks are just at different sites, but that's
Looks like
okay.
a lot of people on Dr. Lee's research team.
I figured you had the inside scoop. I just want to make sure you weren't inappropriately proportioning it all to HSS.
Uh-huh, uh-huh. So this was a large administrative data claims study, which I think we can talk about some of the limitations that that sort of study does entail. I did a lot of that work when I was a resident as well. So GLP-1s, are very common now. The question is, does this have any adverse effect on things like, for most pertinent to hand surgeons, wound healing complications, infections, that kind of thing. So this was looking at 7 years worth of data from the Pearl Diver administrative data set. So what Pearl Diver is, and there's a few different, Market Scan's another one you could use. But insurance companies will contribute their claims data into these commercially available data sets. So this does not include things like Medicare, Medicaid, or workers' compensation. So all these claims are sitting in this huge data set, and you can pay to access this and put a query in and run your questions. Now, again, it's important with these admin data sets to know that this is not actual patient outcomes. These data were not actually collected for the purposes of research. The purposes for billing. So you have a bunch of diagnosis codes, and then you have a bunch of procedure codes and dates and all sorts of things that you could put together and try to answer a question. So what they looked at was patients who had a prescription for GLP-1 agonists within 30 days of a list of hand surgeries, including carpal tunnel, trigger finger, cubital tunnel, distal radius RAF, and maybe one or two others. So they have to have had an active prescription that was filled within 30 days of their surgery. So again, you don't know which one they're on exactly. Well, they don't say which one they're on. They don't say if they're actually taking it because you can't with this kind of data, and they don't say if it's actually working for the patient or how long they've been on it. So these are kind of the main limitations and guardrails around this study. But they looked at a group that had the GLP-1s and propensity matched for a group that didn't have GLP-1s. And what propensity matching is basically trying to get apples to apples in terms of risk for wound issues, infections, other things. So demographically trying to assemble a control group of sorts. And then they looked at outcomes including post-op complications, 90-day readmission, 90-day reoperation for infection, and 2-year all-cause revision rates. So Chuck, take it from here, now that I've nerded out on the methodology.
Yeah, you've done a nice job. Great explanations. And so I think the bottom line was meant to be reassuring to surgeons considering operating on those taking GLP-1s. So users were found to have equal or lower infection rates, lower odds of pneumonia, DVT, etc., lower readmission rates, and no increase in revision or reoperation. And so that's the overly simplistic findings, but those are sort of the take home points. And the whole question of gastric emptying and the like is I guess I would say still in evolution because we talk about that here in the introduction to the paper. The authors mentioned that worry for most GLP-1 takers is really not a major worry any longer. There are certain patients that may have to go on a 24-hour liquid diet or something like that. So it still needs to be discussed. The importance of this paper is one, there's a lot of patients taking GLP-1s that might be increasing. The perioperative risk does not seem to be elevated. This provides evidence to reassure us. And it's really highly relevant for our population where often these are outpatient surgeries. And again, like we started our conversation, we're looking for rapid and safe throughput.
Yeah, no, I think that those are all fair takes on the study findings. I think that one of the things that we ask in our journal club here at WashU is how could this authors have answered this question better, and does this lend itself to any subsequent follow-up studies? And I think that probably if you're going to do an admin data study, you probably can't answer it any better than how they did it. Perhaps they could have tried to parse out a bit more about how long they were on GLP-1 agonists, but even that does have its limitations. The outcomes they measured here, not all specifically relevant to hand surgery. I mean, all cause revision is good, but can you really tell if it's a revision? Because they even say you can't tell a carpal tunnel release versus a revision carpal tunnel release with these data. You can tell laterality usually if it's coded appropriately. But I think the important one about wound infection and dehiscence, you know, that all assumes that things are coded appropriately. So when we're all putting in our codes at the end of the encounter, it's kind of, I'm not always 100% specific in terms of, whether I'm writing down wrist pain or radiocarpal arthritis, for example. But again, with the understanding the limitations of an admin data set, the study I think was well done. Follow-up studies, I mean, I know that we've got one looking right now at how patients do after GLP-1s and very kind of granular prospective data. I do think there are a lot of questions that could be answered. Now, I don't know how long people are going to be interested in this topic, to be honest with you, as the news cycle goes. So I don't know if you think there's any certain follow-up that needs to be done or pertinent to hand surgery.
I think this study was timely and well done and gets to the major points. Certainly, it could be re-explored with a prospective or retrospective single or multi-institutional trial, which may have better data. My personal sense is I haven't seen problems in this patient population. I don't think this is going to remain a hot topic for hand surgeons, and so I'm not personally going to plan a major investigation.
Well timed, Team HSS, well timed. Nobody
Yes.
scooped you first. So, our last article for this episode is an article from the University of Chicago, and it's a changing landscape in surgical treatment of basilar thumb arthritis. Is the rate of denervation increasing? Authors are Daniel Portney, Cody Lee, Jennifer Wolf, Jason Strelzow, and Jeffrey Stepan. Jason's now on Team WashU, and Jeff Stepan, is a former WashU hand fellow. So shout out to Jeff and Jason.
Yeah, so this is a nice study, which again, we don't have to go through the details, but looked at a national insurance claim database, 64,000 surgically treated CMC osteoarthritis patients, looked at CPT, ICD-10 coding to look at really, I guess, five groups of patients. So trapeziectomy plus, maybe I'll leave it at that. That could include suspension or the classic LRTI, and that's a little bit of a gray area in the paper. Trapeziectomy alone, thumb CMC arthrodesis, prosthetic arthroplasty, and denervation. And it looked at trends and looked at a multivariable regression analysis on this, nice study over 6 years. And again,
Yeah, so
this was Pearl Driver too, I believe.
also Pearl Diver study, correct.
Yeah.
So you can see how, I mean, I think these admin data studies are nice. I think the knock on them is that they typically raise more questions than they answer. But it is a nice way to start looking at a question. And I think that if you are looking at a topic for research, it's good to come at the question from different angles using different methodologies. And I've done that in my research career too. So I think that there's value in these admin data studies. And honestly, this trend is really interesting. So, seeing that Denervation was the least common surgery and accounted for only 1% of the cases overall, but the incidence went from 0.47 to 1.3 per 1 million. So, 2.5x basically. Um, in terms of how frequently denervation was performed. And then so Chuck, you mentioned a regression analysis. So, I think just to kind of unpack that for listeners that may not be as familiar with what that is, with the regression analysis, what you're looking for is, what are the things that are potentially contributing to that outcome, from a statistical perspective. So, you look at all the different demographic factors that may influence it, and then you put that into an equation that predicts the likelihood of a certain thing. So if in case you're unaware of that. But I think the point is that denervation is becoming increasingly more common. I think that it's interesting if you look at the actual number of cases. There's only 50 cases of denervation in the first year in this data set, and the most is 287 in the last year of the data set. So that's over millions and millions of patients that are included in this data set. So it's really rare. But it'll be interesting to see how that changes over time. I think that the hand surgery practice will evolve based on the literature and the presentations at meetings, and so many more people are hot to trot on denervation. What's been your experience with denervation so far?
Yeah, I have a couple of thoughts in response. So, first of all, if I was going to see in the future, Chuck Goldfarb does not think this that there's going to be a massive increase in denervations. What I do think, though, is there's going to be a marked increase in arthroplasty, true implant arthroplasty,
Prosthetic arthroplasty.
prosthetic arthroplasty. Thank you. And my personal experience has been that if a patient seems like a great fit, I send them to you. And the great fit would be perhaps someone who has failed a different surgery, perhaps someone who is not interested in the surgeries that are offered, wants something minimally invasive with a fast recovery. Younger patient, perhaps. Those are sort of the patients I think about for denervation. How do you think about that as a surgical option?
I think of a denervation as a time buying procedure. I don't think it's definitive. You're creating a Charcot joint, but again, in the right patient, it can work. I think that there's denervation, then there's complete denervation. So, are you mainly cutting a couple of branches? Are you doing the full on, like if you do a real denervation, like that takes time. And it's not a small surgery. The recovery is quicker because you're not doing any bone work, but it is not a small surgery. And, if you're really getting after all the branches. So I think that, sometimes it's probably a long run for a short slide, but in the right patient, it's worth considering.
Yeah, my two final comments for this paper are number one, I will do it, and you can roll your eyes if you want, as the listeners probably will as well. I do a heat shrinkage procedure in certain cases. I do think that has a part
I
of
didn't see
that
that list. I didn't see that listed here.
because what was the minimum number of
Fifty.
derivations done? Yeah,
50.
so we're probably looking at a quarter of that for the heat shrinkage, but there's a derivation component to heat shrinkage, let's be honest. And my second comment is those who are not in the United States might question the fact that 84% of our patients in the US from this Pearl Diver group was 84% were trapeziectomy with some type of suspension plasty. And I assume the rest of the world still favors simple trapeziectomy as has historically been the case.
Or, I mean, the rest of the world is doing a lot more implant arthroplasty. So prosthetic arthroplasty, I know I won't name the actual implants, but I know there's a lot more evidence that's being gathered. We had a visitor from South Africa a couple of years ago who was definitely mentioning his excellent outcomes. You see it throughout the European, when you look at the FESH, program, it's all over it. So I think that it is a case of American exceptionalism, as we see often, that we are not going to change what we do. But I think we will have to change because I think more patients are finding out about it. In terms of, just like hip and knee arthroplasty companies are reaching out direct to consumer, direct to patient, these companies will start reaching out to patients and, marketing to them. And we're going to have to say, we don't do it for these reasons. Or one of us, maybe one of our partners wants to be the one to do it in our group. And I think that'd be, Dr. Wright. I'm going to volunteer him for now. Just kidding. But, I think that we're going to have to learn more about it and kind of change our ways because there are some patients just don't do as well with, the standard way that we treat patients in the States.
That's right. I mean, the hand surgeon community has been immune to a lot of the direct consumer advertising, except for collagenase, of course. And I do have to answer that question. John Elway, well, I heard John Elway talking about this. So we may face more of that. I think you're right.
Yeah, and I think that some of the, I know that the ultrasound guided carpal tunnel manufacturer does reach out direct to consumer, to market that. So yeah, there's different technologies, smaller niche markets, but they're starting to do it. So that was our first go at doing this JHS Journal Club. We've got three more articles to discuss in our next episode, but we wanted to thank Nash and Macarena and Dr. Merrill for the opportunity to talk about these articles, and hopefully you guys like us talking about this. Give us feedback on whether this is working, whether you like hearing about this, and these will include the articles in the show notes in terms of making sure you get access to them.
Perfect. Well, let's do it again real soon.
Oh, we will.